Bismillah ar-Rahman ar-Rahim. Dear fifth year medical students, we will complete the second part of our lecture, the endemic causes of hepatomegaly. This is the list that we have started for the infectious causes of hepatomegaly. Our concern now will be for the mononucleosis glandular fever caused by the Epstein-Barr virus and the cytomegalovirus infection. First of all, this is an introduction for the types of the herpes viruses group for which the Epstein-Barr virus and the cytomegaloviruses are part of them. We have 8 types from the herpes simplex type 1, type 2, and varicella zoster, herpes virus type 3. The Epstein-Barr virus is herpes virus type 4, and the cytomegalovirus is the herpes virus type 5. And we have type 6 and 7, and at the end, type 8 is the virus which is concerned for the Kaposi sarcoma. These are the diseases that are concerned with each virus. The Epstein-Barr virus causes the infectious mononucleosis disease, and the cytomegalovirus causes cytomegalovirus mononucleosis diseases. We will start with the infectious mononucleosis. The incidence of infection mononucleosis range between 50 to 100 cases per 1,000 population, and it's common in younger age. The most common cause of transmission is the oral secretions via the saliva. They are calling it a kissing disease, but also it can be transmitted via the blood transfusion or after bone marrow transplantation. The general consideration of the Epstein-Barr virus. As we know, it's a type 4 herpes virus, and it's one of the most presented human viruses. Infection more than 95% of adult population worldwide, and it persists for lifetime of the host. The infectious mononucleosis manifestation could occur at any age. In developing world, it occurs in younger ages and tends to be less symptomatic. Transmission of Epstein-Barr virus, as we discussed, is most common by the saliva, and that's why they called the kissing disease. And the saliva could maintain secreting the virus for a period of time during a convalescence for 6 months or longer. The incubation period of the virus is almost 4 weeks. The clinical manifestation of the Epstein-Barr virus as general signs in the early phase is presented as fever, sore throat, fatigue, malaise. This is unspecific general features of viral infections. The physical findings, we have 5 important signs we should look for in our patients, like the lymphadenopathy, which exists in 95% of the cases. The most important site is the posterior cervical chain. The description of the lymphadenopathy, they are discrete, non-suppurative, slightly painful, and especially as for the posterior cervical chain. Also, we have what's called Hoagland sign. It's a transient bilateral upper lid edema. Splenomegaly, which exists in 50% of the cases. Maculopapular rash, this is in 15%, but take care because ampicillin and amoxicillin, they might rise the cause of the rash and seen in 90% of the cases. And oxidative pharyngitis, and this will be challenging to differentiate it from the streptococcal sore throat or pharyngitis. The complication of acute disease are more common among older populations. As we see now, this is the Hoagland sign, the edema of the upper eyelids. And this is the pharyngitis with the enlarged tonsils with oxidate resembling streptococcal pharyngitis. So if you are treating a patient with streptococcal pharyngitis and you found there is no improvement and the patient developed rash, we have to be oriented with the Epstein-Barr virus infection. SWAP will be helpful for those patients to differentiate between the viral infection and the streptococcal pharyngitis. Also, the posterior cervical lymphadenopathy chain enlargement with the sore throat. So in general, we have lymphadenopathy, Hoagland sign, pharyngitis, and in the peripheral blood sampling, we have a lymphocytosis with more than 10% atypical lymphocyte. This is very characteristic feature in the lab to discriminate the Epstein-Barr virus or the mononucleosis diseases from other infections. And don't forget that 50% of those cases have splenomegaly, which is regressing after infection. This is the shape of the maculopapular rash, which exists in 15% of the cases. And of course, the penicillin, ampicillin, and the amoxicillin specifically will enhance this ratio, increase the risk to more than 50% of the cases. Other clinical features, and this is one of our aim, hepatitis and cholestatic hepatitis could occur in 11% of the cases. But in a biochemical profile, we will find abnormal liver functions in 90% of Epstein-Barr virus infection. So this is one of the common infectious viral infections in affecting the liver, but the presentation could be detected by the or during the biochemical profile. Also, the Epstein-Barr virus could affect the interstitial pneumonia, cause interstitial pneumonitis, the lungs, affect the stomach, affect the kidney, interstitial nephritis, the nervous system, and maybe the lymph node. When they are enlarged, they could cause obstructive airway disease. In the laboratory finding, in the initial phase, as we mentioned, there is leukocytosis with atypical lymphocyte. This is pathognomonic for the Epstein-Barr virus or the mononucleosis disease. Also, hemolytic anemia could occur or thrombocytopenia, and this is due to cross immune complex activity due to the production of the anti-I cold antibodies, which occasionally occurs with the Epstein-Barr virus infection. As we mentioned, the abnormal liver function could exist in 90% of the cases. So if you find a patient with abnormal liver profile and they have features of viral infection, we have to get a low threshold for the mononucleosis-like diseases with the Epstein-Barr virus or the cytomegaloviruses. To diagnose the Epstein-Barr virus, one of the pathognomonic tests is the monospot test. This is mononucleosis spot test, consists of heterophile cheap cell agglutination test antibody. They are positive against the viral infection. And these antibodies become positive within 4 weeks after the onset of infection. They are specific, but they are not sensitive. And the other challenge in the children, young children, monospot test is almost negative or always negative. And in 20% of the adult infection, they might be negative as well. That's why they are sensitive. They are specific, but they are not sensitive. This is the laboratory finding. If we find the timeline of the viral infection, and this is the antibody titr with the type of them, we are concerning the timing of the phases of infection during incubation, acute phase, or chronic phase. We have the heterophile antibodies may be absent in young children, and in as many as 20% of the adults, they are negative. But during the acute illness, we have the IgM, immunoglobulin M, against the Epstein-Barr virus capsid antigen, VCA. This is the first antibody to rise up during the incubation period and the acute infection, and it will fall down later on. Meanwhile, there is also a rise of the Epstein-Barr virus IgG for the viral capsid antigen and persists for life. On the other hand, we have also another type of antibody. It's called the Epstein-Barr virus nuclear antigen, IgG tetra. This is the IgG tetra of the virus, which occurs later than the 4th week after infection, and it keeps positive for life. To diagnose acute Epstein-Barr virus infection and discriminate it from a previous exposure, we have to check the IgM titer when it's positive together with the IgG. If we found only IgG of the viral capsid or the nuclear antibody positive, they might be occurs due to previous exposure. PCR for the Epstein-Barr virus DNA is very important to diagnose special challenging cases. It starts during the incubation period and end up in the acute phase. So in case of viremia, this indicates there is an active infection, and we could rely on the PCR in case of associated malignancies, as we will discuss later, and the PCR DNA in the CSF could discriminate between CMV, meningitis, or the primary CNS lymphoma in immunocompromised patient like in AIDS. The differential diagnosis of the mononucleosis, this is a mononucleosis-like syndrome, like cytomegalovirus infection and toxoplasma and acute HIV infection, syphilis, herpes type 6, and drug hypersensitivity reaction with mimic features of mononucleosis disease as it occurs with the carbamazepine and phenytoins, and they are anti-epileptic medications. So how we could discriminate the Epstein-Barr virus as one of these mononucleosis-like syndrome from these 6 causes? It will be challenging, but the oxidative pharyngitis is absent and the heterophile antibody tests are negative during infection. And these could be the landmarks to differentiate it from these other features, depending on the other also serological tests to diagnose each of them. The complications of the Epstein-Barr virus might be secondary bacterial infection, or bacterial pharyngitis could be on top of the Epstein-Barr virus infection. Those patients with the splenomegaly, they might have a 1% spontaneous splenic rupture. That's why we advise them to avoid trauma or collagenous contact or sports. Acalcular cholecystitis or acute fulminant hepatitis with massive necrosis could affect the liver. And very rare complication for the heart is the pericarditis and myocarditis in Epstein-Barr virus infection. How to treat them? The general measures is this is a self-limiting disease in 95% of the cases. As any virus, it's clear and cures spontaneously. So what we could do is to provide symptomatic treatments in the form of non-steroidal anti-inflammatory drugs or acetaminophen and warm saline for the throat irrigation and gargles for 3-4 times a day. Antiviral with the acyclovir is not helpful, not of clinical significance, but some physicians could use it to decrease the duration, but there is no evidence for this. Steroids, corticosteroid therapy, although widespread, is not recommended in uncomplicated cases. So it's not recommended for any patient with Epstein-Barr virus infection, only in a special situation like airway obstruction from enlarged lymph nodes, hemolytic anemia, or severe thrombocytopenia. In those 3 cases, we are allowed to use corticosteroid to decrease the immune response against the complications, to reduce the size of lymph nodes, and to reduce the amount of hemolysis or the thrombocytopenia if they are at a critical level. But there is no evidence, or it's not well established, to use the corticosteroids with other complications like ruptured spleen, pericarditis, myocarditis, or CNS involvement. Throat culture grows beta hemolytic streptococci 10 days course of penicillin or azithromycin is indicated in case of Epstein-Barr virus infection. We have to avoid the ampicillin or the amoxicillin because they will increase the risk with rash. So be cautious with the ampicillin in case of Epstein-Barr virus infection. Treatment of complications, if there is hepatitis, myocarditis, or encephalitis, are treated symptomatically. Ruptured spleen are treated surgically with surgical repair or splenectomy. Those patients should avoid vigorous sports for at least 4 weeks to decrease the risk of ruptured spleen. The prevention and the prognosis. In uncomplicated cases, fever disappear in 10 days and lymphadenopathy and splenomegaly will disappear in 4 weeks. But the fatigue could be stayed for longer duration, 2 to 3 months. Hand washing after contact and avoidance of close personal contacts with active cases, and there is no available vaccine to prevent against Epstein-Barr virus infection. There is another associated syndromes, and these are very important to be oriented with, that Epstein-Barr virus is one of the oncogenic viruses, which induces in the young children Burkitt lymphomas and or in the adult nasopharyngeal carcinomas. And also there is X-linked lymphoproliferative syndromes, which means that those patients with chronic Epstein-Barr virus infection, they have risk of developing lymphoproliferative hematological malignancies. The Burkitt lymphoma is one of the malignancies that affect the facial bones in young children, and they found it endemic in Africa because they have high risk of Epstein-Barr virus, and they found that the DNA exists in their serum in 90% of the cases of Burkitt's lymphoma. And of course, they are treated with a chemotherapy. So Epstein-Barr virus might induce malignancy, and they call it associated syndromes, Burkitt lymphoma, nasopharyngeal carcinoma, or lymphoproliferative disorders. We will shift now to the second type of virus that might affect the liver also. It's called the cytomegalovirus. This is a herpes virus type 5. Herpes virus type 5 consists of DNA. After exposure to the cytomegalovirus infection, most of them are asymptomatic after primary infection, and the virus remain latent in the blood, in the most of body cells. So it's one of the latent infections. Latent infections mean that this virus might be flared in the future when this patient is immunocompromised or exposed to stress. And we will discuss what are the type of these patients later on. The seroconversion in adults of Western developed countries range between 60 to 80%, but this seroprevalence is higher in developing countries like in Egypt. It might exceed 95% of our population could have the sero markers of the cytomegalovirus in their serum. Transmission occurs through sexual contact, breastfeeding, blood contacts, or transplantation, which means those patients or recipients will develop solid organ transplant. They are at higher risk to acquire cytomegalo infection via the transplant organ, because the cytomegalovirus is living in the most of the body cells. It might occur also from person to person or via the congenital transmission or cause congenital infection. And we will show you what are the types of the congenital viruses that might, or infections that might affect the baby during the pregnancy. So the serious disease occur primarily in immunocompromised persons, including those with inflammatory bowel disease, IBD, which means that those patients who are exposed to immunosuppressive therapy, like the inflammatory bowel disease, or after organ transplantation, liver, kidney, or bone marrow, due to the massive immunosuppression, these latent infection could be flared. Also, those patients who receive chemotherapy are at high risk of this. So we have to be oriented in those patients as a high-risk group that there is a virus, it's called cytomegalovirus, that might be flare up when they exposed to immunosuppressive situation that will increase the or flare the viral infection later on. There are three recognizable clinical syndromes in the cytomegalovirus. The prenatal disease, from the pregnant lady to the young, to her fetus, or cytomegalovirus in immunocompetent persons, or cytomegalovirus in immunocompromised cases. In congenital infection, we know the common infections, it's called TORCH, refer to toxoplasma and other pathogens like syphilis O and R. rubella, German measles, and the C is the cytomegalovirus, and the H stands for the herpes simplex viruses. If the pregnant lady they have an active infection in one of those infectious diseases, they will induce congenital infection for the coming baby. And the cytomegalovirus is one of them. So one of the affections of the cytomegalovirus for the females in the prenatal disease, it's called congenital cytomegaloviruses. And we will discuss this as in most of common congenital infection in developing countries, about 0.6% of live birth, with higher rates among lower socioeconomic groups. The transmission is much higher from the mother with primary disease than those with reactivation. The incidence in the patient, the mother with a primary disease, and 40% that her child will get the cytomegalovirus infection. And this percentage will be reduced to 1% or 2% in case of reactivity during her pregnancy. And about 10% of the infected newborns will be symptomatic with cytomegalovirus inclusion body. And we will see how the virus will affect this baby in the next slide. Here, as we see, this is cartoon which is showing cytomegalovirus, and there is D, and every letter will stand for symptom or disease later on that we have to focus to diagnose cytomegalovirus infection or congenital cytomegalovirus. Like C is the chorioretinitis, M stands for microcephaly and mental retardation, motor retardation, and V is the periventricular calcification, and D for deafness or hearing loss. And these are the symptoms and signs of the congenital cytomegalovirus. Also, hepatitis is one of the symptoms and signs for congenital cytomegaloviruses. In case of immunocompetent persons, they acquired acute cytomegalovirus infection. It's most common with mononucleosis-like syndrome. As we mentioned, this is one of the 6 or the 7 differential causes of mononucleosis-like syndrome with a negative heterophile antibodies. But pharyngitis might happen with the cytomegalovirus because the virus is from the same family of the Epstein-Barr virus group. In critically ill immunocompetent adults, cytomegalovirus reactivation is associated with prolonged hospital stay and maybe death, but this is very rare. The disease in immunocompetent person in acute cytomegalovirus infection is fever, malaise, myalgia, and arthralgia, splenomegaly. Again, differential diagnosis is the oxidative pharyngitis and cervical lymphadenopathy are uncommon in case of cytomegalovirus, not the same thing as the Epstein-Barr virus. Cutaneous rash could exist, especially with ampicillin again. So this, how to differentiate the Epstein-Barr virus from the cytomegalo. Complications includes mucosal or gastrointestinal damage, encephalitis, severe hepatitis, thrombocytopenia, or Guillain-Barré pericarditis and myocarditis. A mononucleosis-like syndrome due to cytomegalovirus can be also occur after splenectomy. In case of immunocompromised patient, and this is the great challenge, that cytomegalovirus in those patients will be presented as a latent infection, which means that the virus exists in their body and they will flare up, the virus will flare up when the patient immunity is going down. So these situations are solid organ transplantation or bone marrow transplantation are at high risk for a year after allograft transplantation, but especially the first 100 days afterward are the most critical time, which means this period of time at which the patient has the higher doses of immunosuppression to avoid rejection until the allograft became immune tolerant. So they might develop cytomegalo infection, or acquire cytomegalo infection, or they have high chances of reactivation of cytomegalo virus infection. Also, they could acquire this infection from the donors. So the serostatus of the donors and the recipients are very important in those patients, which means we might have donors with positive serology for cytomegalovirus infection, and the recipient, they are negative for this, which means that the recipient has not exposed to the virus before. They are at high risk to develop cytomegalovirus infection post-transplantation. And that's why we are obliged to give those recipients prophylactic antiviral therapy for the first 3 months post-transplantation. Cytomegalovirus diseases in HIV, also they could causes serious infections, especially in the eye, to cause CMV retinitis or CMV gastroenteritis, especially if the CD count is less than 50. As we know that the CD cells is one of the T lymphocytes, which play an important role as an orchestra for the immune system to control or enhance the immune response against any pathogens. And the HIV infection disabled the function of these cells. That's why those patients in HIV patients are at high risk to develop several lethal infections. And if this cells count is reduced to less than 50 cells per microliter, those patients will be exposed to a high risk of cytomegalovirus infection of the CNS or the eye or in GIT or the lungs. In CMV retinitis associated with intravitreal delivery of steroids, this is they are affecting the eye. The serious gastrointestinal CMV infection might occur after transplantation or chemotherapy or steroid therapy due to any other autoimmune diseases like rheumatoid arthritis, systemic lupus, or whatever. So any person who are exposed to immunosuppressive therapy or considered to be immunocompromised due to malignancy, due to chemotherapy, due to organ transplant, due to immunosuppressive treatment, they are at high risk of serious GIT CMV infection. Also, CMV pneumonitis could occur or affecting the neurological organs, especially in those patients with AIDS. This is called disseminated CMV infection in immunocompromised patients. How to diagnose those cases? In case of pregnancy and the newborns, the mother should be checked for the cytomegalovirus viremia every 3 months if the assay during the first 3 months is seropositive. If the lady, because this is one of the congenital TORCH, as we mentioned, congenital infections occurs during pregnancy, so the gynecologist should be oriented with these types of infection to be screened during pregnancy, and the congenital cytomegalovirus could be diagnosed as early as the 21st week after aspiration, a sample in the amniotic fluid at which the cytomegalovirus could be excreted in the amniotic fluid. Of course, this is the 21st week of gestation during pregnancy. Of course, we could rely on the PCR to detect this type of virus, or the ELISA for the IgM against cytomegalovirus infection. In immunocompetent persons, one of the pathognomonic features, as we mentioned, the absolute lymphocytosis with atypical lymphocytes in 10%, and the abnormal liver functions. Again, it could occur, it's very common in those cases during the first 2 weeks, and often 2 weeks after the fever persists for this. So any patients with abnormal liver functions, this could be those patients should be screened against the cytomegalovirus or Epstein-Barr virus, as we mentioned. And the detection of cytomegalovirus DNA with PCR or IgM is diagnostic, but also the rising titer of the IgG fourfolds to the baseline could support the diagnosis of acute cytomegalovirus infection. In the immunocompromised cases, of course, the CMV retinitis depends on the diagnosis of it, depends on the ophthalmological features. The CMV patients depends on the serology and their diagnoses. CMV PCR is very diagnostic in 2 organs, if they affect the lungs or if the cytomegalovirus affects the gastrointestinal tract. And that's why the PCR might be negative in the serum, but they are positive in the tissue in these 2 infections, if there is CMV pneumonitis or CMV colitis. As we mentioned, CMV colitis occur in the absence of detectable viremia. Also, the PCR is very helpful in the immunocompromised patient post-transplant to guide the treatment and the prevention. As we mentioned, depends on the status of the donor and recipient to start the treatment. And also, if they receive the treatment, when to stop, depending on the negative viremia in the post-transplant situations. This is radiological features of the CMV pneumonitis, and this is very fatal to 60 to 80%, from 60 to 80%. This is CT chest, showing the increasing the density in both lung infiltration due to cytomegalovirus infection. And this is the conventional chest X-ray, which shows the features of bronchopneumonia, as we see with the small radiopacities in the lung, indicating interstitial pneumonia. Also, the biopsy is very pathognomonic, has pathognomonic feature of the cytomegalovirus. As we see, this is the owl eye appearance when we take tissue biopsy and we found this sign indicates cytomegalovirus inclusion, intracellular or intracytoplasmic inclusion bodies, which are a feature of cytomegalovirus infection. We could rely on this in case of CMV pneumonitis or CMV gastrointestinal diseases. Also, the CMV PCR could be helpful in the tissue in these two affections, the pneumonia and the GIT. How to treat the cytomegalovirus infection? 2 antiviral medication, valganciclovir, this is the oral antiviral, and the ganciclovir is the intravenous antiviral therapy. Of course, for non-severe and post-transplant CMV infection, we could give either one of them. There is no problem. But in case of severe cytomegalovirus infection or serious affection, we have to go to the intravenous form. The ganciclovir is the drug of choice. The duration of treatment is to decrease the level of viremia, because the virus will be reactivated or inactivated after treatment. So our aim is to reduce the level of viremia at least for 2 weeks until the virus is cleared from the blood. So we have to get 2 consecutive negative CMV PCR count before discontinuation of the antiviral therapy. Also, the prevention is one of the major measures for the pregnant lady to avoid getting cytomegalovirus and to acquire congenital cytomegalovirus for the future baby. So avoid kissing and sharing foods, and hand hygiene is very important for or during pregnancy. The ART is the antiretroviral therapy, is effective. This is the treatment of HIV patients. It's also one of the important lines of treatment during management of cytomegalovirus in HIV patients. So we are not depending only for the antiviral therapy, but in the HIV patients, we have to start the ART whenever it's indicated to avoid or preventing cytomegalovirus infection. Also, cytomegalovirus immunoglobulins to reduce the bronchiolitis obliterans in bone marrow transplant population is used in the centers as part of prophylaxis in kidney and liver and lung transplantation. So there is immunoglobulins against the cytomegalovirus in order to decrease the incidence of reactivity or flaring up after transplantation. This is now we accomplished the required ILOs for the endemic causes of hepatomegaly, as we mentioned in the second lecture. And I hope the lecture is fruitful for you. And if there is any questions, please contact me. There is no problem. And thank you.